Thank you, everyone. I'm delighted to be here today, and I'd like to thank the organizers for inviting me to beautiful Redwood City. And it's been great to meet and re-meet many of you during this wonderful weekend. So my topic is from defining health disparities to improving health equity in cystic fibrosis. And really, I want to talk about how, in spite of the great advances we've had in diagnosis and therapy, we're actually widening health disparities through those advances. And we have to really be sure that policy and practice must advance so that every person with CF has a fair and just opportunity to attain their highest level of health. And everyone in this room can do this, because regardless of whether you're a scientist, a clinician, a parent of a person with CF, or another member of this community, you have a voice and you can advocate. And we heard some wonderful advocacy last night from Ray. So I'm going to start with the positionality statement. I think this is important. On the left-hand side of this slide, there is a wheel of privilege and power. This is from Canada. I use it intentionally because this exists throughout the world. So I am a person who is a US citizen, whose parents were US citizens. I am not from an indigenous culture. I have white skin color. I am a cisgender heterosexual person. I went to college. Both my parents went to college. 2 of my 4 grandparents went to college. 3 of my 4 grandparents were born in the United States of America. So I have oozes. I have so much unearned privilege. I walk through the world easily. And one of the things that we have to recognize in the United States and in other cultures that are European, particularly Northern European, or their colonies, we have this perspective that white is normal and that everything else is different. And even the history of a lot of diversity efforts, a lot of school efforts has been to make people from different cultures whiter, because white is assumed to be the healthiest and the best. And so as we talk about disparities, it's really important to note how whiteness and white culture has not only neglected people from different backgrounds, but actually increased disparity, stress, and social injustice in communities. I'm showing this. This is a art display from a few years ago called Witness Whiteness, which was really focused on this. And the artist who put this together is a Latina lesbian who's also my sister-in-law. So the arts can tell us a lot. I'm going to start with definitions, language, and historical context, because anytime I come into a room, I don't know where everyone is. I want to do some level setting. And so you've probably seen a version of this cartoon before. Equality is this: we treat everyone the same. Equity is we give everyone the opportunity to have the same perspective. Reality is that not everyone has the same power, privilege, or ability to do the same thing in the same way, even if you're striving for only equality. And liberation is giving people freedom to be as well as they can be, to manifest themselves in the world and be their best person. Health disparities are defined as differences in health among population groups. This is an epidemiologic term saying that these people are sicker or more well than those people. Inequity are health disparities that are unfair or stem from injustice. And we're going to talk about a lot of those today. In the much of the literature I'm going to cite, the term minority is used, and you have heard this: racial and ethnic minority. I want to be very careful in how that's portrayed, because in some of these slides, I do cite literature the way it's written. Minority in an appropriate context is a mathematical construct. So it's less than half of the whole. You know, you all did math in school. So a person is considered a minority group if they differ in some way from people within a specific population. So if they're less than 50%. So many of you know the wonderful Samia Nasser. She was born in Jordan. She does a lot of work in Egypt, but she's a citizen and she works in Michigan, but she's from a minority group in the US. If I go to the Middle East, which I was supposed to in 2020, but then this thing happened, I would be a minority. So, but people do use this also to say like, oh, that was just a minor problem, like it's not important. We don't want to use it that way when we're talking about disparities. I prefer the term minoritized, and this is a racial, religious, political, national, or other group thought to be different from the larger group of which it's part, but importantly has little power or representation relative to other groups in society. And I will tell you a story, and I'm going to show this, some data from this paper. A few years ago, Megan McGarry and I put a paper into pediatric pulmonology, and we used this word in the title, and the reviewers were just beside themselves, and it was clear that they weren't going to allow it. So we changed it to minority, and then I became editor-in-chief of the journal, so we can use language the way it means. It's a lot of work, but it was worth it. So race and ethnicity, you've heard this before. These are social constructs. They have no biological meaning. Race was made up politically to categorize people so that there could be enslavement and classes that benefited those with the most power and privilege. It has, and this is a citation from Dorothy Roberts, who's a critical race theory scholar, staggering biological consequences because of the impact of social inequality on people's health. Now, ethnicity is defined by shared cultural heritage, sometimes ancestry, language, or religion, but it also is not to be constructed as a biological difference. And furthermore, if you start reading literature from around the world, the way people define these things is wildly different. There is, however, this concept of ancestry and genetic variation, which is, it's actually still socially constructed. But if you remember that humans first emerged in Africa, and then they immigrated to different places, sometimes in relatively small groups, there is genetic variation around the world that is not something that you can look at by race, but you can use ancestral genetic markers, which are a spectrum, and you see differences in gene variants. And that's true both for gene variants that cause no disease and those that cause disease. So if you look at this map of the world, it gives higher to lower prevalences of cystic fibrosis, but you have to recognize that all of these areas in gray, nobody knows. There's usually no sweat testing available. Many of these are low and middle income countries where public health dollars go into sanitation, vaccinations, and there's not a large healthcare system. So we don't actually know this, but it's important in the context of some of the information that I'm going to present. Another big controversy is how and why to use concepts of race and ethnicity in research at all. And so years ago, the Institute of Medicine, which is now the National Academy of Medicine, recommended collecting race and ethnicity to identify needed improvements in healthcare. Think about that as we go along. And it measures representation in research too, which crosses, cultures, and there are some genetics that get in there, but not because race is genetic. So that is the standard in the United States that's actually being more enforced, particularly in, for example, FDA clinical trials. But in some countries, it's actually forbidden to collect these data. So when we do international clinical trials in cystic fibrosis, we have missing data because of the country law. It's also important to note the long history of race-based medicine and abuse of people in the healthcare system in medicine, particularly in the United States. So these are some quotes from Dorothy Roberts again, that medical students have been taught to take the patient's race into account. So think about what Ray said last night. Think about people who've been told it's not very likely because you're Black, or because you're South Asian. So much of this goes on. It's in current clinical practice. And there was a study done just a couple of years ago where medical students actually, a high proportion of them believe that Black people have thicker skin and don't feel pain as easily. This is still in the parlance of medicine as it's practiced today, and it's false and it's wrong. And most Americans believe that some version of a biological concept of race is true. Harriet Washington wrote this book called Medical Apartheid, which is the very bleak, disturbing history of how Black people, particularly but not exclusively enslaved Black people, were subject to atrocities in the name of medical research. And I think everyone in the room is familiar with the Tuskegee study of syphilis, in which men with syphilis were not treated as a natural history study and underwent all kinds of procedures, being told that there was treatment. And even when penicillin became available for that treatment, the natural history study continued. That natural history study closed when I was already a teenager. You've all heard about implicit and unconscious bias, but these are these automatic stereotypes that interface with our brains. The benefit of it is that you can make a quick decision based on something, but it also causes people to treat others differently, not listen to them, not believe them. And it is very clear from published studies that US healthcare professionals favor white and light-skinned persons, and that this has adverse effects on patient-provider interactions, treatment decisions, adherence, and patient health outcomes. These are not old papers, by the way. You may know, and you may not know, about the long history of race adjustment of pulmonary function. And so this was something that justified enslavement of Black people in the United States because it was good for them to do manual labor because their lung function was lower. What makes your lung function lower? Poor nutrition, poor air quality. Exposure has more to do it with genetics. So what this means is that if you had a Black person and a white person with their lung function measured, the Black person's lung function will look higher. That in cystic fibrosis could affect if you're eligible for a modulator trial, if you're eligible for a transplant. Now, in 2014, this was written in an elegant book, Breathing Race into the Machine, about this history of spirometry and how it was used and abused. And that was a few years after one of my colleagues published this paper in the New England Journal of Medicine that showed that race is a terrible predictor of pulmonary function. And that if you look at ancestral genetic markers and their distribution, that's much better. So, you're a little like your parents. So that makes sense. The American Thoracic Society published an official statement recommending that this not be used. You know how long that took? That was a couple of months ago. So we've had a lot of information that has continued to be applied to clinical practice, even though there's clear evidence that it causes inequities. I won't go into this in great detail, but not surprisingly, there is very good science that states that just being exposed to racism or experiencing racism has strong effects on your general health. And these are not moderated by age, sex, birthplace, or education level. Children just seeing other people being treated with racist behavior also have negative health effects. So let's move now to health disparities in people with CF from racial and ethnic minority groups. I'm using that demographically. So this has always been important, but we need to recognize that the US population is becoming more diverse. So if you look at the proportion of people in various, these are census-based race and ethnicity categories, which themselves are wrong, but it's all we have to use. We see that there is a large growth in populations, and this big white, this big blue bar is white, not Hispanic people. And then we see this in cystic fibrosis. So this large study of newborn screening that I've been conducting with many collaborators, we found that about 7% of infants born in the United States between 2010 and 2018 who had cystic fibrosis were Black. If you look at the data in the registry, it's more like 3-4%, 13% Hispanic. These are not mutually exclusive. So this is who has cystic fibrosis. And you see that there is a major difference between the CFTR mutation classes, with 33% of infants from minoritized groups being in an unclassified using these criteria group. And that represents many more rare variants. So that will become important shortly. We've known for years that there's increased mortality in minoritized people with cystic fibrosis. Hispanic people with CF have an 85% increased risk of death, and Black people with CF 48% compared to non-Hispanic white people with CF. Notice how that's like a reference group in this paper, as much of this research is. Hispanic people with CF have a mean age at death that's almost 6 years earlier than non-Hispanic white people. And in California, only 75% of Hispanic people with CF survived 18 years after diagnosis, compared to over 90% in non-Hispanic white people. These are pre-newborn screening era data, but that only makes one I'm going to tell you in a little bit more important. And I have to thank Megan McGarry, who made the original versions of these slides. So I already told you Hispanic and Black people with CF have worse mortality, but they also have worse lung function. And so if you look at the disparity, again, with Hispanic people and non-Hispanic white people with CF, it's significant, and it starts very early in life. Similarly, Black people with CF have a lower percent predicted lung function. This is even with race adjustment, so it's even lower. And this hasn't really been studied since the late 1990s. Megan's done some work on infections, and so a couple of years ago published this paper showing that the Hispanic CF population got their initial Pseudomonas aeruginosa at a younger age. Very recently published another paper showing that the same is true of Staph aureus. We don't know the origins of this, but it's true. So why does this happen? Particularly in Hispanic people with CF, they have a higher body mass index. That should make you healthier. They have more pancreatic sufficiency, so milder CFTR variants, and those should cause better outcomes. And if we just look at socioeconomic status, and a lot of people will say, well, it's because less money, but you can't take that out of a person, but you can statistically adjust for it. These disparities persist. And I want to point out that respiratory health inequality, and actually health inequity, crosses conditions, it crosses geographies. This is a recent ERS monograph, European Respiratory Society, on inequalities in respiratory health. And you can't read that, but that's all of the background and then what the inequalities, as they call them, look like across different diseases. So this is not just cystic fibrosis, but there are specific things in cystic fibrosis that we have the opportunity to change. And this is a complex slide, but it's available on the website of the National Institute of Minority Health and Health Disparities. And so it talks about biologic, behavioral, physical, sociocultural, and healthcare system influences on health, and then the levels of influence, individual, interpersonal, community, and societal. We overly blame people, individuals, or in family units on their poor health outcomes. That is the framework of a lot of medical visits. And until we look at this more contextually, we will not be able to overcome health inequities. So now I'm going to get to really the major topic of this talk, which is how our biggest advances in CF diagnosis and treatment increases health disparities. And I am in favor of and conducted research on and helped to implement things like CFTR modulators, the advent of newborn screening. And I would propose that the health benefits that we've seen in the CF community over the past 10 years are due to those two things. But there is a widening gap. So this is 2022 survival, as estimated by the CF Foundation, 56 years. When I started doing this, it was half or maybe a little bit less than half. So that's, woo, and it is, it's good news, but, oh, and this slide was shown earlier by an earlier speaker, but pointing out that we actually made a lot of progress before modulators. That just caused an inflection point. And I think as kids can start on these disease modifying therapies earlier, we will see even more and more. But these breakthroughs are associated with inequities. And I'm going to start with modulator therapies and then go to newborn screening. So you guys remember this guy on the left? I liked him. He was from my state. I have a good friend who is good friends with him and Michelle, and she had a VHS tape of one of her kids throwing up on Mr. Obama, and she got rid of it. It's kind of too bad. But anyway, this is when he announced the Precision Medicine Initiative. Do people remember that? This has turned into the All of Us program, which seeks to get a much more diverse representative population in genetic, environmental, and self-reported data, along with electronic health records. But the guy he's shaking hands with was one of the first people to get ivacaftor. And he was talking about how Kalydeco had been life-changing and really setting this goal with CF and modulator therapy as an example for what could be done with precision medicine. And this has been very much in the lay media over time, ivacaftor, and then more recently, Alexacav, I can't even say it, Trikafta. So best health news over the last decade. And so where are we now? So these highly effective modulators are available to about 90% of US people with CF based on their CFTR gene variant. And not everyone who has genetic eligibility can actually tolerate or take these medications, but there's wide coverage for most people. And you probably saw the press release that ivacaftor is now available for people who are 4 weeks old and older. Those are hard trials to do, by the way. But that is the last milestone for that particular drug. And then the elexacaftor, tezacaftor, ivacaftor has gone through clinical trials much more rapidly than the previous modulators. So it's now approved for people who are 2 or older. So that's exciting, but not for everyone. So this is from the same data set that I showed earlier, just looked at a different way. So if you are white and not Hispanic, you have about a 90% chance of having F508del, which makes you eligible for Trikafta. If you are Hispanic, you've got a 70% chance. If you're Black, 60-ish, if you're Asian. So this is a very marked disparity for these highly effective therapies. And this is even with some label extensions, there's still a huge change in eligibility. So another issue we have is underrepresentation in trials for which people are eligible. So this is a paper that Megan led in 2016. 82% almost of CF clinical trials didn't even report race or ethnicity. And these were mostly not modulator trials because there weren't as many of them. And there she is. No, that's not her. Sorry, I saw blonde. If it was reported, over a quarter had no participants from racial and ethnic minority groups. So it's a big problem. It's a big problem still. If you look at it graphically, this is the overall participation in CF drug clinical trials, but in people from minoritized groups from 1999 to 2015. And this is still a problem. So this was a letter written after the reports of the Trikafta studies came out, and they didn't do a demographic table that included race and ethnicity. So this was a letter to the editor, and then they responded, first of all, they agreed and they did publish the distribution, but this is a really convoluted explanation. The prevalence of this mutation among people with cystic fibrosis is only 15 to 25% in North Africa and Turkey, but about 75% in Northern Europe. Well, first of all, these studies were not done in North Africa and Turkey. And second of all, that is still, if it's 15 to 25% only, then 15 to 25% of people should be from those backgrounds. So it was not, there was a response, it was not satisfactory for me personally. So let's move on now to newborn screening. So the most important thing for you to understand as we go into this is that CF newborn screening improves outcomes. And this slide is a little hard to look at, but cystic fibrosis for most people is fatal in early life if it's not diagnosed. If you have pancreatic insufficiency from birth, you can die of malnutrition, vitamin deficiency, or salt loss, hyponatremia, before you're even diagnosed. But for people who are diagnosed, your childhood weight and height predict not just your lung function, because we've all heard that multiple times, but actually how likely you are to live until you're an adult. So this is a paper published in 2013 that just showed kids starting at age 4. Again, this was newborn before newborn screening, this cohort. But if your weight is weight percentile is less than the 10th, in that blue line, you're much, much less likely than if it's greater than the 50th, our goal for people with CF, to live to 20. So this is a pretty contemporary cohort. So we have to keep that in mind. And then, Phil Farrell led a randomized controlled trial of newborn screening in Wisconsin, in which they screened everyone, but only recalled half of the kids. But there was a safety net. So nobody actually went undiagnosed. If they weren't diagnosed early, they went and found them. So it wasn't as bad as it could have been. Also, cohort studies. So clearly showed a benefit. And so the Centers for Disease Control of the United States recommended screening for cystic fibrosis to be added to the newborn screening panel for all states in 2004. You need to know, if you don't already, that what is screened for and how it's screened is a state decision. It's a state public health decision. It is not and nationally, there are recommendations made on what to screen for, but not how. So that plays in a lot to what I'm going to say next. This is a slide, it's a little bit pale, but this Margaret Rosenfeld led this study, and it got quite a bit of press because it actually shows that newborn screening is working the way we would expect it to. So if you look at these blue bars, that's a cohort of people before newborn screening, and then the yellow are after, and this is all age adjusted. So from early life, you've got better weight, you've got better height, and you've got better pulmonary function. And you'll note on this bottom panel, if you look at that graph, and the colors aren't projecting all that well, but the lung function is actually about the same when it's first measured in the early years of life, but then the newborn screening group is better than the not screened group. And this is because you have lung disease that's silent, that doesn't play out in your lung function until later. But very strong data. So again, woohoo, it's working, but we've got problems. So in the newborn screening guidelines, it is recommended that everybody is seen in the first month of life by 28 days, ideally. We split these data up a little bit differently. So what you see is in the dark blue here, most kids born between 2010 and 2018, that's 2010, I should have mentioned, is the year that every state finally did newborn screening. So it took a while for everyone to get on board and get their programs organized. But so most did, but look at that very long tail and how many kids are diagnosed after 30 days, 40 days, 60 days, and even on into the first 2 years of life. So many kids are not benefiting. Now, if you look at the distribution of when someone is first seen for testing or clinical evaluation or both after, well, I can't say after positive newborn screening because the way the registry is set up, there's a little fuzziness. But since we started newborn screening, kids who are not Hispanic and white are seen at a median age of less than 20 days. There's a shift over for kids from minoritized groups. But what's really important is the curve. Let me see if I can get this pointer to work. Yeah. So this is, you see that this peak is way lower than that peak, and that there's this big curve over here. So some of these kids are being seen for the first time at a CF center when they are much, much older than they should be to get the full benefit of newborn screening. And we see here that the white non-Hispanic kids, their weight at the first year, 12 to 24 months of age, is above 0. So this is a Z-score, which is a statistical way of looking at data that makes it easier. So a Z-score of 0 is normal for the general population of people. Below 0 is less, worse nutrition. But again, see this tail over here and how many kids are down here 1 to 2 standard deviations below that. So why is that important? I'll get to in a minute, but public health practice really influences the detection of cystic fibrosis. So when you have fewer CFTR variants analyzed on a newborn screening panel, and all states now use some form of genetic testing in newborn screening, you're going to detect fewer people from minoritized populations. So this is a study that Megan again led, where we looked at all the people in the CF registry by their reported race and ethnicity. And then we looked at all the different genetic panels that are used by US states. And we looked at the number, and this is just two of them. One is the one that's the lowest number that's often used, the American College of Medical Genetics 23 panel, which we know is based on people with European ancestry. And then the Illumina 139 sounds like a lot of variants, right? But even with these, you're going to miss a lot of babies, and particularly Black and Asian babies, but also a lot of Hispanic babies with CF. This little map up here shows the panel number. So all these states with the darkest color filled in solid are testing for at least 139. There are a couple of states that this is showing up differently here too. I don't know what's going on with the color scheme, but until recently there were two. Now there is one state that only tests for F508del. I showed you the data. That state is Mississippi. They have one of the largest percentage of Black people in the state of Mississippi in the United States. They only test for that gene variant. Now, this is compounded by diagnostic bias. And Ray told you her story of diagnostic bias last night. And this is just something from an infographic that I'm going to show you in a minute about the fact that we have so much delay. But cystic fibrosis has been seen as a white person's disease. How this evolved, I think, just had to do with language most common in people of Northern European ancestry, because Dorothy Anderson, who first reported cystic fibrosis, pointed out that it occurred in people from all races and geographies. That's the way that she did it. But here we see Michelle and Terry Wright. Many of you know them. They founded the National Organization of African Americans with Cystic Fibrosis. They have been on the road talking about this. But families get this, and we did some work through the CF Foundation, through NOAASF, and these are just some quotes, some of them a little bit altered to not, tell other people's stories, but I was told my child's CF was impossible because I'm Puerto Rican and my husband is Black. I was told my child did not have CF based on a negative newborn screening test, even though his brother has CF. I was accused of not feeding my child with failure to thrive. No one was listening to me. This happens. Our community has suffered from this. In terms of some other whys, in addition to the nutritional issues, babies who are diagnosed later with CF, this is a median of 47 days. So it's like under 7 weeks. They're much more likely to be hospitalized with a pulmonary exacerbation in the first year of life. Early lung disease is something else that has a health trajectory that's negative, and this can be prevented by starting therapy early. So how do we make this better? This is a quote from Ibram X. Kendi, scholar at the University of Pennsylvania now. Racial inequity is a problem of bad policy, not bad people. And so how do we reduce the gap in highly effective therapies? Well, we need to have disease modifying therapies for everyone. Even with better representation, even with testing rare gene variants, there are people who are going to not make a CFTR protein. If you have no protein, you can't be modulated. So genetic therapies, but also ion channel therapies. We studied these before there were modulators, kind of fizzled off, didn't get a good one, but there are lots of things that can be done. And then this concept of CFTR scaffolding in improving the protein structure without a modulator type of therapy. So they're gene variant agnostic. I can't explain that to you. I've just read about it and it's very cool. The other thing we need to do is we need to be sure that we are giving people good health care and to improve the trustworthiness of healthcare. And this is foundational to giving every person the best care that they can get now, regardless of what treatments we have, and also something needed if we are ever going to be able to have full engagement of a representative population in clinical trials. I already showed you Harriet Washington's book, but this paper was by a couple of health equity researchers at Johns Hopkins. COVID-19 racism and the pursuit of healthcare and research worthy of trust. So we in the healthcare field and organizations that support improvements in healthcare need to be worthy of trust. And we need to look at the what the literature says about trust and barriers to research participation. We need to have a diverse workforce. I'm not going to go into all of this, but you have heard this before. And then we need to improve detection and diagnosis for everyone. So I'm very fortunate to be leading a grant funded by the U.S. Centers for Disease Control, Chronic Disease Prevention Program, and we are raising awareness. And this is a partnership across CF centers, public health experts, and NOAASF. I've shown you that we need these changes in newborn screening. There are now 719 CFTR variants known to cause disease. One state is testing for all of them today. That's Wisconsin, because they were using a next generation platform. And using that platform, you just decide what you want to called out, and you can add them infinitely. We have to reduce bias in healthcare, and we have to work towards racial justice and real community engagement, which isn't like I'm doing a study, come tell me how I could get people like you to participate. It's actually asking people from the very beginning to help make studies. And I'm just going to end with this one, which is a statement about love. So when you think about caring for people broadly, you have to think about love. And I have this quote from Avedis Donabedian. Raise your hand if you know who that is. All right, we got one in the back. Avedis Donabedian is credited with starting health care quality improvement, and was very rigorous, used a lot of statistical methodology, but as he was at the end of his life, he said that ultimately the secret of quality is love. If you have love, you can work backward to monitor and improve the systems. We need more love in our community. And then I'll wrap it up with Bell Hooks, who was a scholar. She died a couple of years ago. You should read her works. The moment we choose to love, we begin to move against domination. We begin to move towards freedom, and we act in ways that liberate ourselves and others. So take that away, that we need to practice medicine, interact with each other, and conduct our research with love. These are my many collaborators and funders. Thank you very much for your attention.